Hello, everyone. Once again, welcome to the first affiliate hospital of Harbin Medical University. You are seeing the live demonstration case from our new CAS lab located in the Nangang district, our branch. And today we are very excited and privileged to make this live case demonstration on a very classic CHIP patient. And we are very glad to have this opportunity to share our daily experience and our daily work. And I want to take this opportunity to express our special thanks to Dr. Mehta and all the other colleagues in the MedStream 360. Thank you. And I'm going to introduce the leading operator of today, Professor Jingling. And the second operator today is Dr. Shi Xin and Dr. Wang Tengyu. And I'm the moderator of today. I'm Dr. Cao Yang. Okay, I'm going to give the rest of the time to Dr. Wang Tengyu to make a general introduction of the case for today, which is the classic CHIP patient.
Hello, everyone. Let me introduce this case. This patient is a 65 years old female with a 1 month history of chest pain. She had diabetes, heart failure, and hypertension. Her coronary risk factors are hypertension, diabetes, and smoking. Her blood pressure and heart rate were normal at admission. Laboratory examinations showed elevated levels of blood glucose, total cholesterol, LDL, and BNP. An ECG shows a significant STT change. UCG showed left ventricular ejection fraction is reduced. 32 point. She was diagnosed as unstable angina pectoris, hypertension, heart failure, and ejection fraction. Left coronary angiography shows LCX is dominant, and 99% stenosis at proximal. And the left coronary angiography also showed moderate stenosis in the mid part of LAD. Right coronary angiography showed CTO of proximal RCA. LAD revealed many collectors to RCA while the septal branches and the left ventricular apex. There are many some collectors to RCA while the septal branches. The QFR is 0.86 in the middle LAD. These patients underwent PCI into L6 with one stent 1 month ago. We can see there are some good collectors to RCA where the septal branches. That's all. Thank you.
Okay, thank you, Professor Wang Tengyu. I think that we have a general idea about this patient. This is an old lady and with a relatively low body weight, over something 45 kilogram or something. And then we can see that it's a triple vessel disease. And 1 month ago, we finished the revascularization of circ. And this time we are focusing on the rest of the RCA occlusion. So maybe I give the rest of the time to Professor Jingling to give an introduction of the angiography for today and also the strategies of today.
Okay, good morning, everyone. Now let's see the first angiography. This is a patient of 3 vessel disease. We have complete revascularization of LCX last time, and this time we will focus on the RCA. And the patient's LAD QFR value, LAD was 0.81. So we plan to defer LAD and work on ICA this time. Antegrade approach is the first choice in this case, since there is seems macro channel by bilateral angiography. Contralateral collateral flow from septal to distal RCA is not close. Let's see this paragraph. The contralateral collateral flow from septal to distal RCA is not close. For antegrade approach, Caravelle microcatheter is my first choice. Now we see the next.
So we can see the stent in the circuit is patent. And I noticed that we have implanted IVP, right, for this lady.
This patient infection fraction is 32%.
Okay, so we have implant IVP for the left ventricular support.
Now we use Caravelle microcatheter and XTA.
Okay, filter
First.
XTA, yes.
XTA first.
Okay.
Then we find in the proximal, the XTA is punctured into the fourth lumen. So we change Gaia first.
Okay, so Professor Jing, I noticed that this is a relatively small lady with a relatively low body weight, and from the angiography and also the CT angiography before this procedure, we noticed some calcification, and this is a long diffuse lesion. So you just mentioned that for the antegrade approach, you tried the parallel technique and also the wire escalation technique. So could you give us some general introduction of your personal, how to say, experience, how to apply the wire escalation technique? Because you just mentioned you used filter family wire and then switched to the Gaia first wire. Why do you perform these strategies? And is there any each point that we can learn from this approach?
Okay, this is a good question. We know GetWare uses strategy of antegrade wire escalation technique for CTO is important. We find that we use XTA is not punctured into the truth lumen, so we change XTA. For CTO lesions with tapered tip, it's recommended to start with a tapered tip design wire with a low to moderate perforation power, a polymer coated guide wire. Some operations may be accustomed to use a non-tapered tip polymer coated guide wire, such as Pilot 50, which is also available strategy. If the initial guide where does not successful pass the occlusal segment, we will change the guide wire. But in this case, we use XTA and then to Gaia 1 because we the first puncture into the fourth lumen, so we change the taper tip guide wire.
Okay, thank you. So I noticed that after switching the, I think that Gaia first wire, it seems that it works very well. That from the contralateral angiography, it seems that the Gaia wire has been engaged into the distal true lumen. So what's our next step for this procedure?
Next time we will test the true lumen of this patient. So we'll use 1.0 Bluetooth delicate to dilate this vessel.
Okay. So I noticed that you use a Caravelle microcatheter to try to use it as a support for the antegrade wire puncture and also switch it to the working horse wire. And okay, I think that this microcatheter of Carovel has been pushed to the distal part of the RCA. So next you switch to a workhorse wire, right? This is seems to be a workhorse wire. So you just mentioned that you use a 1.0 balloon, right? It seems that you meet some resistance at the mid distal part of RCA, and from angiography and CTA, there is some calcification. So how did you perform this dilation using this small balloon? It seems that 1.0 balloon doesn't work, right?
First, we use 1.0 balloon to dilate this vessel, but we meet difficulty. So we change micro dilate balloon, 1.2 plus 12 to dilate this vessel. So we frequently to cross it.
Okay. So the 1.25 balloon is from Boston Scientific, maybe. It seems that the balloon diameter, 1.25 millimeter, is larger compared to the 1.0 millimeter, but the tip entry point of the balloon seems to be smaller with a tapered, at the tip, so it's relatively easy to get engaged. So let's see how did it work with a 125 balloon. Okay, this seems to be the 125 balloon, right, from the Boston. Yes, so it seems that pass through the lesion very smoothly, and also we make some dilation of the long diffuse stenosis. So maybe next we try. Okay, this is the contralateral angiography and identify that the wire is in the true lumen at the distal part. So maybe next time we perform intravascular imaging to identify what it is like.
Next time we use EVERS to test it.
Okay.
If it's a true lumen.
Okay. So maybe some teach point need to be emphasized for this patient. Like I emphasized and Dr. Wang Tengyu introduced, this is a CHIP patient. It's a triple vessel disease. We notice that RCA is total occluded and circumflex is semi-occluded, and also that we performed PCI last time. And RAD, there is a focal mid to severe stenosis. However, QFR indicated that RAD lesion could be deferred because it's only 0.8 something that is about the cutoff value. So that this time our target vessel is RCA. And for this kind of CHIP patient with a relatively, relatively old and small body weight lady, that is a potential high risk for PCI procedure complications. For example, the high bleeding risk, and also that we can see the ejection fraction value is only 30 or something. So before we touch this patient, we have IABP standby for this patient because we notice that its heart function is not that well. And IABP standby is of great importance for this patient because we noticed during the PCI procedure, we can see that the RCA guiding catheter is N plus left 1. After it's engaged to the RCA ostium, we notice that it seems to be, deep engaged, and the blood pressure on the RCA guiding catheter is a little bit damped because the ostium seems to be severe, stenosis. So even though that is RCA, we should notice, pay attention to the blood pressure of the RCA very carefully. And like Professor Jingling introduced, that first we use now Fielder family wire under the support of Carovel microcatheter to try to engage to the proximal cap of the RCA occlusion. And however, we meet some resistance because we know that Fielder family wire is a hydrophilic coated wire. It's associated with a relatively good manipulation and a good wire response. And however, that is a potential high risk to penetrate into the subintimal space, especially at the segment with diffused thick calcification. And for this patient, from the angiography and also the CT angiography, we noticed some calcification as the most severe occluded segment. So that whenever we meet some resistance with the Fielder family wire, it's potential indication for us to switch it's either wear escalation or parallel technique, something. So to avoid the potential hazard to get the filter family wear into the subintimal space to cause some dissection or hematoma, which I mean cause the procedure failure. So that the wear escalation technique is of great importance. Another potential strategy for this procedure, I think that is the retrograde approach, because we know it's a relatively very long diffuse lesion, and there are two segments occluded for the RCA. One is at the proximal part, one is at the mid-distal part. So that if the antegrade approach failed, I think that the retrograde approach is a potential strategy for this patient.
1.5 blue.
Okay.
However, that there are several connections could be noticed from the septal branch to the distal RCA from the RAD. But the tough spot for this patient is that there is some focal severe stenosis at the mid part of RAD. So that is relatively difficult for us to perform the retrograde approach without putting a stent in the RAD, because, for example, the retrograde wire and the microcatheter could cause this severe stenosis of the RAD, block the vessel perfusion to the distal RAD, and also maybe cause the plaque, fracture or plaque rupture or something. So that retrograde approach doesn't seem to be the first choice in this patient. And so we perform the antegrade approach. And after the antegrade wire escalation with the Gaia first wire under the support of Caravel, we noticed that the wire passed through the whole occluded segment very smoothly. And from the contralateral angiography, we identified that the wire is in the true lumen. However, it's hard to tell whether the rest of the vessel is in the true lumen or not. So we can see that after we switched to the working horse wire, now we are using the 1.5 balloon to dilate the whole vessel. And I noticed that it's hard to pass through the IVUS catheter. So it seems that this diffused calcified plaque is associated with some high resistance in this case. And we are relatively familiar with this high resistance lesion. There are several indications for the high resistance lesion. One thing is that relatively tortuous, long and diffuse lesion with calcification. And the other indication is that it's a difficulty in passing through the devices. For example, the balloons, microcatheters, and the associated stenting. It's difficult to pass through the lesion. So this is what we call the high resistance disease. Okay, that's Professor Jingling is working on the balloon dilation, because we can see that IVUS catheter has some resistance in passing through. And here is some questions from the audience online, and thank you for your concern. The first one is that what is your choice for microcatheters? Okay, that I'm not quite sure if you noticed that our choice for the current case is Caravel microcatheter, which is a relatively new microcatheter available on the market. And I think that for me, maybe different operators has their different, preference for the microcatheters. Actually, for me, I prefer the Corsair microcatheter a lot, because the tip of the microcatheter is relatively long and have some good penetration into the vessel. Okay, so that we have put the catheter into the occluded segment. And from this pullback from the RCA, we notice that so far that the whole wire is 222. Everything is that in the true lumen. So this is the good news. But the bad news is that we can see the plaque burden along the RCA is relatively very high. Even after the 1.5 balloon dilation, we can see that the instant lumen gain is not so much. And also the plaque composition is relatively very complex. We notice some calcification, some attenuated fibrotic plaque. And also here seems to be the proximal occluded segment. Still is in the, true lumen, but we notice that very severe attenuated sign, which indicated it's either the lot of fibrotic and lipidic plaque, or it's either there is a potential calcification in the deep part of the plaque. Now it seems to be the proximate RCA, and also the plaque burden is very high. So maybe potential stent length is going to be very long. And also, okay, we have finished the RCA pullback.
Okay.
And then let's put a detailed, observation of this pullback. Okay, this is the distal part of our RCA. Maybe that we haven't seen a very clear and good landing zone. And at the current spot, we can see that the lumen is only around, 2.1 millimeter or something, which is not a large vessel. Here is something that for the CTO vessels, one thing is that we notice for the CTO lesions, majority of the time after initiation of the recanalization, the distal part of the vessel is
Not very high.
majority of the time it's a shrink because there is a spasm or something during the long time occluded. So the artery size might not be, how to say that, can be observed at the normal situation. So sometimes after some follow-ups or after some vasodilators, that the vessel size could be dramatically increased.
Okay.
So this is a very potential hint for us how to choose the right stent size for the CTO lesions, because sometimes after initial of the recanalization, the distal landing zone size, vessel size, doesn't seem to be at the right spot. And after the pulling back to the missed distal part, we noticed some, eccentric calcification, eccentric superficial calcification. It's at least, I think, that 200 degrees or something. So this may require some scoring balloon, preparation for this kind of long lesion. And see here seems to be some, negative remodeling of the vessel. So the plaque modification should be performed very carefully. Let's measure the EM. Here seems to be 3.0 for the EM at that part, and here is only 2.3. So we should pay more attention to this spot because this is some negative remodeling. This is a long diffuse lesion. Okay, everything is in the true lumen. However, that the plaque burden is very high, so maybe some scoring balloon, it's either cutting balloon or an SB balloon could be applied. Otherwise, that it's difficult to put in the stent. So maybe 2.0 cutting,
2.0.
yes, or an SB balloon is okay. And after the plaque modification, we give some vasodilator to see what's it like. Just like I mentioned that for the CTO lesions, majority of the time, the distal vessel size seems to be associated with some spasm or long time of no perfusion. So the vessel size is shrinked. So some potential vasodilator could be applied. Natural Proceed, natural granule, natural glycerin, etc. are also potential good available vasodilators. So now we are using the 2.0 by 10 millimeter cutting balloon to make some plaque modification. And you should notice that the mid-distal part, there is some negative remodeling. The vessel size is not so large, so we do not try to open to a very large atmosphere. Okay, we come back to the question from the audience of our choice for the microcatheter. We know that the microcatheter is of key importance in the Antegrade and as well as the Retrograde approach. Nowadays, that the microcatheter application in the CTO procedures is of very, multiple use. For example, not only just to offer some support to the Antegrade wire, but also we can perform some, for example, tip injection, some wire casing technique to greeting the retrograde Wonderwood technique to greeting the retrograde wire, etc. It's all of great potential use. And relatively, microcatheters can be divided, for my opinion, could be divided into two groups. One thing is the larger microcatheters, such as the Corsair, facilitated collateral crossing, and also there are microcatheters with a relatively smaller diameters, such as the Caravel, for example, the Fine Cross, microcatheter 14, etc. They are associated with a much greater crossability, which is easier to deliver, especially the small caliber epicardial collaterals, and also can provide relatively less support compared to that of a Corsair,
Oh.
microcatheter.
Okay.
And also, some microcatheters are associated with some dilation
sorry.
function. For example,
6.
after
Okay.
passing through this
Ah.
microcatheter, it's associated with some dilation function similar to that of 1.5 balloon. So
6.
this is some potential
8.
advantage of the microcatheter.
Okay.
And for this case, we noticed that Dr. Jingling chose an microcatheter called the Caravel. Caravel microcatheter is associated with very good
Okay.
crossability because the tape and also the tape, I think for my opinion, the tape of the Caravel microcatheter is only 1.4 French, for which is relative and a small caliber, especially for the, the body of the microcatheter is of a small, caliber. So one thing you should notice that you should try not to rotate the Caravel microcatheter too much, or not at all during the delivery of the microcatheter
Slowly.
because it's
Okay.
forbidden for rotation. It's not like the design of combined 8+2 wires for the Corsair microcatheter, which you can rotate clockwise and anti-clockwise within 10 rounds to help to deliver this microcatheter.
Okay, Evans.
Okay. Okay, we after the 2.0 cutting balloon that we make a new IVUS pullback for the RCA to detect whether there is some plug modification or something. Not yet. Thank you.
Wait. Wait for a minute.
So from the engine and also the IVUS, we know this is a relatively long diffuse lesion, so it's associated with a relatively potential long stenting connected to each other. And from the previous manuscript, we noticed that the stenting too long stents, for example, with a small caliber 2.5 or 225 stent with a length over over 70 millimeter is a potential risk factors for the future targeted lesion failure. So we maybe after this one we try to find some potential choice for the still we can see a lot of plaque burden and the distal landing zone, if it is a potential choice, only seems to be a 2.5 millimeter, but the plaque burden is an issue. And we notice that after modification, if the residual plaque burden is still over 60, it's a potential high risk for stent under expansion, especially we can see that some potential yes, this is attenuated segment that we just noticed. And I was image with this over 300 degrees of attenuation is potential high risk of slow flow or non-flow phenomenon. So later we give some vasodilator to make some, preparation for the potential slow flow phenomenon because we can see some high attenuated plaque. Okay, like I said, that from the angiography and also the IVUS, we notice that at the ostium of the RCA is still diffused long lesion. So if we are going to put a stent, we are going to cover the ostium of the RCA. So my suggestion is that maybe we give some vasodilator and we make an angio to see there is any potential landing zone or something. So maybe we give some natural. And then we perform the angio. Did you give some natural?
Yeah.
Oh, already? Okay.
Okay, already.
Oh, okay. Like I said, that the distal part is potential landing zone, and seems to be only a 2.5. So maybe my suggestion is maybe 2.5 cutting balloon or something with some lower atmosphere, and then we try to put a stent in.
2.5.
Yes, for the distal part.
Pre-dilated balloon.
Okay.
2.5
2.5 pre-dilated balloon.
2.5预扩。
So So we come back to the questions from the audience online. Is there a Chinese company that manufactures microcatheters? Yes, we have our own microcatheters. However, due to some technical problem that is not available on the current situation, but we have several companies that can manufacture microcatheters. I think that from the last demonstration performed by the Dr. Li Yue, we have used and then 100% domestic microcatheter in China, which is of good, very good crossability, and also the support for the antegrade wire puncture. This could be a good case for 0.9 millimeter laser. Yes, thank you for your suggestions. Yes, laser is a very good potential plaque modification strategies, especially for the long diffused with associated with a very high plaque burden case. However, we do not have the laser facility in our the laser equipment in our facility so far. So this is a problem. I think that the stand, yes, opens very well. Deflate, yes.
Yeah.
And I think that you consider small rotablator burr. Rotablation, yes, we perform active rotablation for this very tough, very severe calcification case with a high resistance that is relatively difficult to pass through. However, for this case, one thing is that it's a RCA case, and the second thing is that we noticed that with a small caliber balloon, we can easily pass. And also the rotawire, I mean, exchange for this kind of situation is a potential difficulty in this case. So I do not think that the rotablation for this case is a very good potential choice for this patient. So in this case, yes, rotablation is a potential choice for plaque modification. But it seems that it's not our first initial choice. If we could use a balloon to pass through the lesion to make some good modification, then maybe maybe that we do not try to use a rotablation at our first choice. And what is the name of this catheter? You mean the microcatheter, maybe? Yes, maybe later. I'm not quite sure if you are going. If it's okay to show the product or not. Maybe I'm going to try to show this microcatheter for you. I'm going to cover the signs. Okay, I'm going to cover the. Okay, this is the caravelle microcatheter. Okay, the caravelle. Okay, for this one, that is associated with a very good crossability and also with a small caliber of the microcatheter. It's a good potential choice for this one.
New one.
Okay.
It's a caravelle microcatheter. So thank you for your questions. I noticed that Professor Jing has finished the plaque modification using a 2.5 balloon. So next, we are going to try to
2.5, a new one.
Okay. We are going to make yes the second round of plaque modification because we noticed some calcium and very long diffused plaque burden. So we noticed some potential, I mean, intimal dissection, maybe due to the dilation. So we try not to perform antegrade angio anymore. Okay. It seems the balloon opens very well. Here's some superficial calcification, but not so severe. Okay. Maybe higher is fine because yes, the proximal part is okay. There is no negative remodialis.
Okay, done.
So our technician.
8.
So our senior tech, Professor Qi, what's I mean, first stand length? Maybe the first one is 2.5 or something. So what's the stand length for the first one?
Okay.
How long for the first stand? Maybe yes, more. Maybe yes. Okay, later maybe. Because we noticed the proximal and ostium of the RCA is a very high plaque burden. need to cover to the osum of the RCA. So for the first stent, maybe a 2.5 stent, and we how to say?
2.5 cutting balloon.
Okay, sure. Because we notice a lot of long diffused plaque burden.
2.5 cutting balloon.
So Professor Jing, I noticed that for this case, that it seems that you managed to cross the CTO lesion very successfully using only the one wire, the Gaia first wire. However, sometimes the antegrade approach is associated with the risk of going into the subintimal space. So the parallel technique is a potential good, strategy for the antegrade approach. So what's your suggestions and your experience in the parallel technique for the antegrade approach in this case? If the Gaia first goes into the subintimal space, how do you try to manipulate it to re-entry into the true lumen? So what's your experience?
Oh, okay. In the operation, we often use parallel wire guide technique. The application strategy of a parallel wire guidance technique and subtimal re-entry to true lumen. A parallel wire technique is commonly used in the antegrade technique. When the first wire goes into subintimal space, or set branch in the occluded segment, the parallel wire technology should generally be used. The first guide wire is kept under the intima or in the branch as a signpost, and at the same time plays a role in blocking the run path. And the second guide wire is used under the support of the microcatheter to try to entry in the true lumen.
Okay. Thank you, Professor Jing. So that's the parallel technique is very important, especially that the first wire is going into the subintimal space. So try to switching to the second wire. For example, majority of the time is a relatively harder wire compared to the first one. And under the support and the guidance of the microcatheter, and also using the first wire as a landmark to try to look for a different direction to try to puncture into the true lumen is of a potential very important information for this one. And also you may notice that we are using the contralateral angiography from the left coronary artery to make some identification of the wire position and also the distal situation for the collateral flow, which is our potential very important information. And you notice that we are using a guiding catheter, not an angio, catheter for the left coronary artery. And also there is a wire in the circumflex with a potential support and how to say backup for the potential risk factors if something, for example, happens in the left coronary artery. So a wire in the circumflex in this case is a potential very important information. Okay, now we are using the 2.5 cutting balloon for this case. I think that for the plaque modification for the CTO lesions, it's about potential very important information because we need to make the plaque, how to say, dissection in a controlled situation. Also, the plaque should be longitudinally distributed to help the potential, upcoming stent expansion. And also we notice that the stent expansion is of key importance for the prognosis of the patient. And for the scoring balloons, we have NICE balloons with some scoring elements on the surface of the balloon, which is longitudinal to the balloon design. And also we have cutting balloon with some macro blades on the surface of the balloon. And we also have some chocolate balloon with also some scoring element on the surface of the balloon to help to dilate and also squeeze the plaque with some controlled dissection. So this is very important compared to the traditional pale balloon dilation. Okay, we are making the ELVs again to check what the situation is after the 2.5 cutting balloon. Okay, pull back, please.
Okay.
Okay, once again, we notice that after the vasodilator and also the cutting balloon, we can see that the distal landing zone seems to be much better now. So this is, like I said, for the CTO lesions, after the initial, recanalization, sometimes that the vessel size doesn't seem to be at the right situation. So vasodilator and give some time for the artery to, get away from the spasm situation due to the long time occluded situation. So it's very of key importance. This is very important for us to choose the right size of the stent. Otherwise, that potential relatively small stent size is of a potential high risk for stent anterior expansion. So this is attenuated plaque. It seems that after the cutting balloon is getting much better. Now that we can see the border of the vessel, the EM. Eccentric calcification, but not so large. A lot of plaque burden. I think that we are coming to the ostium of the RCA. This is near the ostium RCA. So my suggestion is that after the first stent, maybe we still need some plaque modification for the proximal part of the RCA.
Okay.
So maybe 2.5 something, 30 or 33 or something for the first one.
2.5 stent.
How about 2.5 for the first one? Okay. So the
2.5.
distal landing zone is 2.2 by 2.6. Okay, 2.5.
2.5 stent.
Yes. 30 or something, I think is fine. However, the proximal part need further modification. So maybe 2.75 balloon and later for the proximal part of the RCA. Okay. So 2.5 by 30. Okay. And trying to control the dissection hematoma is of key importance in the CTO lesion, and not only just during the procedure, but also before the stenting, because we know that we should try to avoid antegrade injection under the situation of dissection to avoid hematoma, because a large hematomas is going to cause disasters of slow flow, and also may cause the hematoma to goes from the further to cause some relatively longer stent. And so from the IVUS and also the image that this part seems to be the landing zone, something here. So maybe with a little bit test seems to be landed here.
Okay.
So that this is a relatively long stent with a 30 millimeter, and we can see the proximal part is a diffuse long lesion. So maybe the stent delivery might meet some potential, risk. Another choice is that maybe we can use the collateral flow for the distal landing. Maybe the okay. Okay.
Okay.
特制帽样也行。
拿出来了。
Okay.
Okay. So it seems to be a good landing
6.
zone, and we are going to
6.
open it here.
6.
Okay,
7.
seems to. Okay, I think that
7.
is okay.
7.
Okay, I think it's enough. Okay.
done.
抬脚。
Okay.
存一下。OK。
Ready.
Okay, although that we meet some
10.
resistance during the stent delivery, but we can see that the stent was sent through the proximal CTO segment very smoothly. I think that this is due to the 7 French guiding caster of the RCA with very good support, and also the plaque modification is of great importance in this case.
11.
大点扩性，今天一会儿27再切一下。
12.
So that we can see that backup for the CTO procedure is of potential great importance, because we need to deliver a lot of very important devices, not only the balloon, but also the stent and microcatheter, etc. So the backup of the guiding catheter is of great importance. So in our, facility, the 7 French guiding catheter is, routinely used for the CTO procedures. Okay, we have finished, putting in the first 2.5 balloon. And now we are trying to use a 2.75 cutting balloon for the proximal part of the RCA because
Cutting balloon?
Yeah.
the final pullback of the eye
Fine.
was indicated that there is a high plaque burden in the
Sorry.
proximal part of RCA, especially the
Fine.
ostium part.
I'm
Seventy
fine.
So
five.
that's
Yeah.
some very good plaque modification is important. Okay, let's check the IVUS again to find the second stand. So maybe 2.75 or something, I think.
Okay, 2.75 cutting
Mhm.
balloon.
2.75大吧
Six.
2.5大
4, 6.
Okay, so the second one should be 2.75 stand. Maybe we can open it to a relatively higher atmosphere because the plaque burden is high. So this spot seems to be the attenuated spot that require, good plaque modification.
6. 8.
Mhm. I think for the ostium could be higher, something 12, 14 atmosphere is fine. For the cutting balloon is for the cutting balloon is my first preference because it's associated with a relatively low risk of intimal dissection and hematoma for me compared to the other scoring balloons, because we know that the NSE balloon and the other scoring balloons associated with some scoring element on the surface of the balloon is so much different to that of the
Okay.
microblade
The next step.
with a controlled dissection of the
How long?
intimal.
2.75
maybe.
75.
Okay.
2.75.
Okay.
30 or 33.
Okay. And now that Professor Jing is putting the second stand of a 2.75 by I think 30 or something. For this case, it's a chip patient with a high resistance in the lesion, and we are using several kinds of scoring balloons to try to modify the plaque. And also here is some special situations that after the wire cross the CTO segment, however the balloon or the other devices cannot pass. It's in the situation that the wire passed, but the other devices cannot pass the CTO segment. In our facility, Professor Li Yue has developed a very, special technique that for the CTO segment, CTO lesion under the situation that wire pass and the other devices cannot pass. It's called the seesaw balloon wire cutting technique. It's called the seesaw wire balloon cutting technique. It's very special. After the first guide wire has passed through the lesion successfully, and the other devices, for example, the 1.0 balloon and the other devices cannot pass.
Okay.
We can try to use the second wire to send along with the first wire as a landmark through the CTO segment, and use two small caliber, balloons to dilate the CTO segment one by one. First, we use the first one to dilate, and we draw back the balloon, and the second balloon on the other wire got engaged and dilates the whole lesion. And with this seesaw wire balloon cutting, it's a very potential very good advantage and the choice in passing through the CTO segment that cannot be passed.
In this case,
it's called
just now in this case in RCA, when I 这个 1.0 blow doesn't pass through the RCA, so we can use seesaw technique.
Yes.
But we change another. Oh, okay.
Okay, let's make IVUS pullback after the two stand. Okay, that we didn't see the distal center edge, but it's fine because later we are going to make a further probe. I think the first stent, I mean, we haven't performed the NC balloon post dilation yet, so it seems that could be, I mean, opened further after the NC balloon dilation.
哎呦，我很轻。
Mm-hmm.
NC balloon.
It seems that okay, this seems to be the attenuated spot. The stent need further NC balloon post dilation, but we didn't see some We didn't see very severe asymmetry situation in this case. This is the attenuated part. So we need to prepare some natural something because we can see the high attenuated spot. After NC balloon, majority of the time there is a slow flow phenomenon after the highly attenuated plaque under the IVUS image. I think we need one more stent after the NC balloon dilation. So let's measure the third stent length. I think it's going to be a 3.0 stent. So let's see the length.
3.0, how long?
How long? Okay. I think 18, 19, or 20 or something is fine. 20 maybe. 3.0 by 20. So maybe we, yes, post I first and we put the third stent maybe. 3.0.
First, NC balloon.
Okay, so maybe we'll perform NC balloon dilation first to see the situation. So like I said, and also our information from the CT angiography and also the bilateral angiography, we can see that it's a long diffuse lesion with calcification, and the plaque burden is relatively very high.
14.
16.
15.
Okay, done.
Okay.
16.
对，可以。
18.
18.
Ah. 16.
Maybe 20.
18.
20.
20.
Okay.
Okay, done.
Okay, this is a 2.5 NC balloon that we are going to dilate the stent with a relatively high atmosphere because we can see the plaque burden is high and the stent is not well expanded after the initial stent deployment.
2.75.
Okay.
Let's see.
And for this patient, we have performed revascularization of the circ and also the RCA. The RAD QFR indicated can be deferred for some time so that we have finished full revascularization. This is a good promise to the prognosis of the patient, especially for this small lady. I think that CABG for this patient is of a potential high risk. This is a 275 NC balloon.
16.
16.
18.
Okay.
18, 20, 22.
22.
Deflation.
And the primary manuscript indicated that the full revascularization, like this one, is of a good promise to the prognosis.
Okay,
and I noticed that there is a question from the audience online that's asking whether we have some made in China microcatheters, which is the devices that manipulate in China. Yes, we have. One of the microcatheters that is of a potential good use that is made in China is called the instant pass that is made by China by the Huitai, a medical product company in China. It's of several designs in the clinical application. For example, we have the 1.7 French microcatheter, the 1.9 French microcatheter, and also the tapered design like the Corsair with a 2.6 French microcatheter. So we have some very good microcatheter made in China. And last time, I think Professor Li has made a demonstration of these devices. For the Caravel microcatheter, I think that some audience is very interested in it. the carry-well microcatheter is of a potential, low profile and associated with a large lumen of this microcatheter. So the outer profile is small, and also the tip is relatively very tapered. The tip length is 5.0 millimeter, and the entry profile is only 0.5 millimeter, 1.4 French. So we test a little bit maybe. The stent need to cover the entire ostium. I think pull back a little bit maybe. Cover the ostium of the RCA. I think it's fine.
Test a little.
Pull back a little bit. Yes. Okay, I think that is the stent should cover the ostium of the RCA.
Okay.
Yes.
Okay.
看不见都可以。
Test.
飘一个吧。
啊。
飘一个。
So we can see that the stent is not well localized due to the, the ostium of the RCA and also the guiding catheter. So we are trying to float this wire into the aorta of the RCA to try to help the guiding catheter to stabilize the guiding catheter to help us in very precise location of the stent. Okay. Okay, now that we are trying to float a wire in the aorta to try to help to stabilize the guiding catheter in helping us to, put the stent in. I think this is a very good trick that Professor Jingling is demonstrating how to stabilize the guiding catheter for the ostium stent location.
Okay. Stand?
Yeah.
Yes. 3-0 stent. Okay, after the wire has been floating in the aorta of the RCA, we can see that the guiding catheter is stabilized a lot better compared to the previous situation.
Okay.